Today we are going to discuss one of the most common and over discussed topic in both UG as well as PG life on pleural effusion. Even the pleural effusion is such an easy topic, but it's worth discussing in certain aspects because it still holds importance, and we can also discuss about the emergence of certain new criteria apart from the Lights criteria differentiate between a transudate and a exudate. So that's all for the later discussion in the same video, but right now let us put the common thing first, that is the difference between a transudate and an exudate. So transudate versus an exudate. Obviously, the first question that comes, which is the most common, that's going to be the transudate. Almost 80% of the pleural effusions tend to be transudates only. It's very rare to have an exudate. But let us see what are the causes of each and everything. First, before going into the causes, we'll do the pathophysiology. Pathophysiology wise, transudates are generally due to alteration of Starling forces. There are two Starling forces that can be altered. One is the capillary hydrostatic pressure and second is the plasma oncotic pressure. So either an increased capillary hydrostatic pressure or a decreased plasma oncotic pressure, the mechanisms of which you know them already. So this is the reason for development of this transudative type of effusion. Exudate is generally due to excessive capillary permeability. Is going to be due to excessive capillary permeability. Probably due to local inflammation, it's very common. So because of vasodilation, there will be exudation. So that's the reason why you get an exudative effusion. So let us move on to the etiology and the causes. So whenever you think about the etiology, the three things that you have to know, that is CHF, cirrhosis and nephrotic syndrome. That's it. So first is the classic congestive cardiac failure, congestive heart failure. It's the most common transudative effusion type also, and it's the most common cause of pleural effusion overall. So I can tell the most common transudate is CHF, and the most common type of pleural effusion overall in the world is also your CHF only, congestive cardiac failure. And almost 80% of the effusions tend to be bilateral, even though some 20% may remain unilateral. One of the most important signs that gives you a clear-cut idea that the effusion is a transudate and it is due to CHF is cardiomegaly. And whenever there is a cardiomegaly and you have a effusion simultaneously, there is more than 12 times increased risk of the effusion being due to CHF. So that's why this cardiomegaly is a very important sign in many trials and many textbooks. So how can you take that as effusions with cardiomegaly is equal to CHF unless proved otherwise? That's it. Very simple. And many times it's a transudate, all right, but sometimes aggressive diuresis may make the effusion look like an exudate. Because of too much concentration of the pleural effusion fluid, it might look like an exudate. We commonly refer to as a pseudo-exudate. All right. So the next cause, as I told you, it's cirrhosis. Cirrhosis causes effusion usually due to portal hypertension. Portal hypertension causes ascites, and pleural effusion is due to the ascitic fluid that passes through the diaphragmatic defect. Diaphragmatic defect. Clear? So that is what is said to be the theory for the pleural effusion due to cirrhosis and ascites. Remember, for developing this pleural effusion, ascites need not be massive. Ascites even can be very minimal, and it can happen with the minimal ascites also. At the same time, suppose if the pleural effusion is massive, that is referred to as something called a hepatic hydrothorax. And very commonly, the hepatic hydrothorax as well as the pleural effusion, both is very, very common on the right side. Typically in 2/3 of the cases, the effusion as well as hepatic hydrothorax due to cirrhosis tends to be right-sided only, because the defect is supposed to be present on the right side. That's why the theory came actually, and that's been substantiated by some research articles also. So the defect is commonly present on the right side, and that's the reason why you get pleural effusion very commonly on the right side. At the same time, third one you have is the nephrotic syndrome. Nephrotic syndrome effusions generally tend to be very small and very asymptomatic, and they tend to be bilateral as well. But there are some other pathophysiology also. For example, in CHF, there are two pathophysiology that are operating. In fact, all these three things, one common pathophysiology is there in CHF, cirrhosis, as well as nephrotic syndrome, that is RAS activation. Because of low perfusion to the kidneys. All these have low perfusion to the kidneys. We have a lot of reasons for that. We'll discuss later on. But all these disorders have a classic RAS activation, and these are classic conditions of RAS activated states. Clear? CHF, cirrhosis, nephrotic syndrome. Even if I ask you in sleep, you have to tell CHF, cirrhosis, and nephrotic syndrome as RAS activated states. So if there is going to be RAS activation, you are going to result in excessive sodium reabsorption, and because of that, you will result in sodium overload, and for the same reason, you might get edema and third space collection. So this is reason number one. Apart from that, the CHF directly causes elevated capillary hydrostatic pressure because of the back leak and venous congestion. So this is one reason, venous congestion. Apart from that, your cirrhosis, I told you, it might be due to direct diaphragmatic defect causing a pleural effusion. So a lot of reasons are there, but remember all these three conditions are classic RAS activated states. That is also contributing to the pleural effusion. In nephrotic syndrome, in fact, this is the usual reason for the pleural effusion. That's the only reason, in fact, for the pleural effusion as far as nephrotic syndrome is concerned. But cirrhosis and CHF, you have other mechanisms also operating, which I told you already. Apart from that, you have a disease called constrictive pericarditis. Constrictive pericarditis. Usually the evidence of constrictive pericarditis is very simple. We'll be discussing in detail about constrictive pericarditis in the cardiology section. But the evidence is two things you have to know. One is pericardial knock on examination, which is a diastolic sound. Again, we'll discuss in the cardiology section. Then, if you have a calcification or thickening of the pericardium, and this calcification of the calcification of the pericardium can be found out in the lateral chest X-ray easily. But very importantly, many times you won't have a calcification. Instead, you will be having just a thickening. So this calcification or thickening of the pericardium can be better appreciated through a CT scan. Clear? Where more than or equal to 4 mm pericardial thickness will tell you it's likely to be a constrictive pericarditis. Less than 2 mm rules out constrictive pericarditis because it's a normal thickness of the pericardium. Let us see some of the other causes of pleural effusion also. Other cause of pleural effusion, that is a transudate, include a peritoneal dialysis related pleural effusion. It's also referred to as PD pleural effusion. The pathophysiology of peritoneal dialysis related pleural effusion is very similar to ascites, where irrigation of the peritoneal area with your peritoneal dialysate fluid will result in movement of this peritoneal dialysate fluid through diaphragmatic openings into the pleural space. That is why the peritoneal dialysis related pleural effusion also tends to be most often right-sided than left-sided. And how will you find out the peritoneal dialysis related pleural effusion? First of all, history of peritoneal dialysis, especially CAPD, itself is a very important clue. Number two, there will be some important characteristics of the peritoneal dialysate fluid which will be reflected in the pleural fluid also, because it's the pleural fluid, the peritoneal dialysate fluid that's entering the pleural space. So the same characteristics will be there. The most important characteristics will be the pleural fluid protein will be extremely less. It will be less than 1 grams per deciliter. Plus, at the same time, the pleural fluid glucose will be extremely high, which means the peritoneal dialysate fluid will contain a lot of glucose that is actually needed in the form of dextrose, actually, that is needed for the osmotic action of the peritoneal dialysate fluid, which to remove the water from the body when the patient is going for a peritoneal dialysis. So that is needed, and that's what you're going to see in the pleural fluid also. Often the peritoneal fluid glucose, the pleural fluid glucose will be more than 300 milligrams per deciliter. Very, very high, which will be even sometimes more than the serum glucose itself. It's impossible unless until it's something else. It cannot happen naturally. Number two, you can get in patients who are having a urinothorax, and again it's a transudate. It's the urine that is entering the pleural space. That's as simple as that, which means the pleural fluid characteristics will be similar to that of the urine. First characteristic is that the urine doesn't have glucose, so the pleural fluid also will not have a glucose often it will be 0, which means I can tell very, very low. Remember, transidates generally are not known to have such a low glucose. This is a very important example of a transidate having almost no glucose. But an exudate generally, it's a very common thing to have a low glucose, but transidates are not known to have. This is one transidate that has a very, very, very low glucose. Similarly, one more confirmatory thing is the pleural fluid creatinine. If you take a ratio with the serum creatinine, it will be more than 1, which means the pleural fluid creatinine is more than the serum creatinine, which again is impossible unless until this is the urine. Okay. Number 3. You can get in pulmonary embolism. Remember, in pulmonary embolism, 25% of the pulmonary embolisms are transidates, and remaining 70% of the pulmonary embolism are exudates. And number 4, you can get in Meek syndrome. Meek syndrome will be given in multiple areas. It will be given as a transidate, it will be given as an exudate. But because if you take textbooks, standard textbooks like Fishman also, both transidates and exudate causes will contain Meek syndrome sometimes. So that's why, but according to the standard textbooks, many Meek syndrome supposed to be a transidate. That's why I'm writing the transidate. You know the Meek syndrome triad, which is very, very commonly asked in any clinical exam. That is an ovarian fibroma with an ascites and a pleural effusion. And it is also supposed to be the fact that ascites is the reason for the pleural effusion here as well. And that is the reason why this pleural effusion tends to be right-sided very commonly. As simple as that. Then you might get this pleural effusion with atelectasis transidative type, that is called atelectasis related pleural effusion, very common again. Then you can get with a very rare congenital disorder called yellow nail syndrome, which is a triad of yellow nails, pleural effusions, and probably your lymphedema. And associated bronchiectasis will be there, which you have seen already in bronchiectasis chapter very detailedly. Then let us come to the exudate. Exudate, you know, it's due to increased capillary permeability, and there are certain etiologies for exudate also. But first one tends to be the pneumonia. The pneumonia causes the parapneumonic effusion, and this parapneumonic effusion tends to be the most common cause of exudative effusion in the world. I can write this is the most common cause of exudative effusion in the world. Remember, it's generally sterile. Parapneumonic effusion is generally sterile, which means the organisms don't invade the pleural space. Generally sterile. Or you might result in a complicated parapneumonic effusion where the organism starts invading the pleural space. So if it's complicated means there will be invasion of organism into the pleural space. I already told you what are the signs of a complicated parapneumonic effusion in pneumonia chapter itself, where pH will be less than 7.2, LDH may be more than 1000, or culture sensitivity may be positive, or even gram stain of certain organism may be positive. I'm not telling gram positive organism, some organism gram stain is seen in the pleural fluid. Clear? So this is what we called as a complicated parapneumonic effusion. Or you might result in pus formation also. That is what is said to be an empyema. When you aspirate a frank pus, that's an empyema. So your spectrum is generally very different. It could be just a sterile parapneumonic effusion without any invasion at all, just a reactive effusion, which means sterile means it's just a reactive parapneumonic effusion. It can become complicated because of the invasion of the organism into the pleural space, or it can become a frank pus also, resulting in the formation of an empyema. So it all depends, but remember, parapneumonic effusion is said to be the most common cause of exudative effusion in the world. Number 2, malignancy. Among the malignancy, the most important is the primary lung cancer. Most common cause is the primary bronchogenic cancer or lung cancer, or it can be coming from the metastasis. Typically, metastasis means from the breast and the lymphoma, or very rarely it could be from a mesothelioma. Diagnosis is very difficult, especially when you want to diagnose a mesothelioma, but you will have history of asbestos exposure somehow in occupation. So point number 1. But you have one important criteria called increased pleural fluid, osteopontin, or increased pleural fluid, fibulin. Increased pleural fluid, fibulin 3. So these two things will increase the likelihood of diagnosing a mesothelioma. But apart from that, mesothelioma in exams definitely will have a history of some form of asbestos exposure very long ago, like 25-30 years back. And mesothelioma has a very, very, very poor prognosis, average survival of only 2 to 3 months in fact. And lung cancer causing a pleural effusion is a very important thing to know. Why? Because a lung cancer causing an effusion, malignant pleural effusions due to lung cancer, note the point, not reactive effusions, malignant effusions or malignant pleural effusions due to lung cancer is inoperable. That's why that is important point. TB, tuberculosis related pleural effusions. Let us see separately how to diagnose TB related pleural effusions. In general, they will contain more than 50% lymphocytes, which means they are predominantly lymphocytic effusion, and their ADA is going to be more than 40 more often. Clear? So if it is less than 40, you can almost rule out tuberculosis, and if it's more than 70, it literally confirms it's a TB. So ADA, especially in countries like India, you have a very good diagnostic role. You can do something called a clinically diagnosed TB, even if you don't have a microbiological confirmation of a TB. This ADA sometimes may help you in starting the treatment using a fact called clinically diagnosed TB, which is still applicable and it's still a well-known rule in a TB patient to treat according to RNTCP guideline. Number 4, lot of collagen vascular disorders, or you can call it as CTDs, connective tissue disorders. Typical example is rheumatoid arthritis, and second one is an SLE. These are the two things that you have to know. RA-related pleural effusions tend to be large and very, 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 very low glucose. This is I don't know how much this point is important. If they ask you the prototypical example of such a low pleural fluid glucose, you have to tell it's rheumatoid arthritis. Second, SLE, the effusions tend to be small usually, and they tend to have either a normal or only a mildly reduced glucose. So these are very important points again. RA and SLE related pleural effusions. Then you can get in other conditions like Wegener's granulomatosis and Churg-Strauss syndrome. Some examples, that's all. Then fifth one, you can go to a whole new world called the gastrointestinal cause of pleural effusion, where 3 are most important. Clear? One is pancreatitis. So pancreatitis can be diagnosed by increased amylase in the pleural fluid. Typically, the pancreatic amylase will be increased. Why? I'll tell you that fact. Next is you have something called an esophageal rupture, and typically here also your amylase in the pleural fluid will be increased, but in this condition your salivary amylase will be increased. That's why I told you particularly the point pancreatic amylase in the previous one. And you can get with certain abdominal abscess also, but please note that pancreatitis and esophageal rupture related pleural effusions tend to be left-sided very often. Very important point. Then there is an entity called a hemothorax. It's the blood in the pleural space. That's it. It's a hemothorax. How can you confirm it's a hemothorax? If your hematocrit of pleural fluid effusion and the hematocrit of the blood, if you compare, if it's more than 50% or more than 0.5, which means what I'm trying to tell is the hematocrit of the pleural fluid is more than 50% of the hematocrit of the blood itself. So that is what we call it as hemothorax. Clear? So usual causes of this hemothorax will be very commonly a trauma, pulmonary embolism sometimes, malignancy can cause bleeding into the pleural space, aortic dissection. I have seen 2-3 cases of aortic dissection presenting with pleural effusion, and we take the pleural fluid, it comes fresh blood and it's a hemothorax. And initially we thought it's not, it's something else. And when we took a CT and the radiologist asked for a CT angiogram because he was suspicious, and then we do a CT angiogram, it was a dissection, extending into near the pleural space and dissecting into the pleural space, causing bleeding into the pleural space and presenting as hemothorax. 2 to 3 cases we have seen. So this, I cannot forget this cause, aortic dissection. And similar cause is aortic aneurysm. Dissection is also a type of aneurysm, but it's a false aneurysm. Or it could be due to a coagulopathy, use of warfarin-like substances. Or it could be a pulmonary AV malformation or a vascular malformation. These are rare causes. Very commonly where we encounter is in the trauma only. So hemothorax. After this, you have pulmonary embolism. As I told you, 70% of the cases of pulmonary embolism tends to be exudative efficiency only. Then chylothorax. Chylothorax. The diagnostic point about chylothorax is very simple. There are 2 points. You have to see the pleural fluid triglycerides. Pleural fluid triglyceride levels. Triglyceride levels may be more than 110 milligrams per deciliter, or it could be in the range of 50 to 110 milligrams per deciliter, or it could be less than 50 milligrams per deciliter. More than 110 milligrams per deciliter confirms diagnosis. This is a definitive chylothorax only. Less than 50 definitely rules out diagnosis. It's not a chylothorax for sure. This is the intermediate range, 50 to 110 milligrams per deciliter, and you have to see the pleural fluid chylomicrons. You have to look for the chylomicrons. If chylomicrons are there, again you can call it as a chylothorax. If chylomicrons are negative, it's not a chylothorax. Clear? So this is how we establish a diagnosis of a chylothorax. So in a simple way, how can you tell the diagnosis? The triglyceride level more than 110 milligrams per deciliter or in the range of 50 to 110 plus the presence of pleural fluid chylomicron. So this will confirm the diagnosis of chylothorax. And very commonly chylothorax tends to be on the right side. And usual etiology for this chylothorax will be thoracic duct damage. This thoracic duct damage generally happens due to a trauma. And this trauma generally is supposed to be iatrogenic. Iatrogenic during thoracic surgeries. Or it can happen due to malignancies also. Or you have a disease called LAM. It's a very, very important cause of a chylothorax. Clear? LAM happens in reproductive age group women. It also has a higher incidence of osteotuberous sclerosis. Even in sporadic patients, the TSC gene is the one that is usually involved in development of this LAM, lymphangioliomyomatosis. And these women have estrogen sensitivity, and these cysts in the lung are generally thought to be due to the estrogen effect and accentuated by the estrogen effect. And that's why pregnancy is one of the contraindications. One of the diseases that have contraindications to pregnancy is this lymphangioliomyomatosis. And these patients are going to have a recurrent chylous pleural effusion, and they're going to have recurrent pneumothoraces due to rupture of this cyst. And CT will show us this cheese appearance. All these things you're going to see in the ILD chapter. Clear? So no need to worry about that right now. So LAM is a very, very, very important cause of a chylous effusion. Lymphangioliomyomatosis. And treatment wise, you can put an ICD here. In the sense, I should not write an ICD anymore. So you can write this as a chest drain. At the same time, we can use octreotide plus or minus medium chain fatty acids, MCFA. So these are the general treatment. Octreotide is to reduce the chyle output. That's the reason why we give octreotide. Apart from the chest drain is to drain the pleural fluid. So if suppose the medical therapy is not responding or poorly responsive, then you can do VATS, video assisted thoracoscopic surgery, and this is supposed to be the best. Clear? Suppose if VATS is not available in your center, alternative therapy is open surgical ligation of this thoracic duct. And this thoracic duct is typically located in a triangle called Poirier's triangle. Poirier's triangle, this is where the thoracic duct will be usually located. So this Poirier's triangle is formed generally between 3 structures. One is the arch of aorta, and second one is the left subclavian, and the third one is the vertebra behind. So these 3 structures form a triangular area called a Poirier's triangle, and in this only you will have this left thoracic duct. And this is a very common question in exam, this Poirier's triangle, and he should know that. And the esophagus is the one that forms the floor actually of this triangle. over which the thoracic duct will be present. So I can write esophagus here. Esophagus will be the one that forms the floor of the triangle actually. So left subclavian vertebra and the arch of aorta, and esophagus forms the floor. In this triangle only you will find the thoracic duct, and that's what we called as a Poirier triangle. And there is something else we have called as a pseudo-chylous effusion. Pseudo-chylous effusion, typically they have a triglyceride level of less than 50, which means it's not a true chylous effusion, but the fluid will be milky. That is due to increased cholesterol. Why increased cholesterol? Because of chronic inflammatory conditions like rheumatoid arthritis or tuberculosis. Very commonly, that's where you see the pseudo-chylous effusion, rheumatoid arthritis, tuberculosis. Because of long-standing inflammation, the WBCs come to that area, and once the WBCs end up their lifespan there, they are going to lyse their cells, and the cholesterol that is contained in the cell wall, and the cells are not cell wall, humans don't have cell wall, so cell membrane, the cholesterol will be there, and that will be, dissolving into the pleural fluid, causing a chylous and milky appearance. So this is what we call it as a pseudo-chylous effusion. Typical examples are chronic inflammatory states like rheumatoid arthritis and tuberculosis. So there are some other few causes of exudative effusions. What are the other few causes of exudative effusions? Post-CABG, after coronary artery bypass grafting, generally tends to be left-sided. And Dressler syndrome, this is a post-MI pericarditis. We have a good amount of discussion in the cardiology about this Dressler syndrome. Again, tends to be left-sided. So patient will have pleuritis, pericarditis, pericardial effusions, pleural effusions, left lower lobe consolidation, and arthritis. So it's a late pericarditis that happens after myocardial infarction, and it's an autoimmune condition. It's thought to be due to autoimmune activation. So this is called Dressler syndrome, late post-MI pericarditis. And you can get in uremia. Please understand that uremic effusions generally tend to be exudative only. Only nephrotic syndrome related effusions tend to be transudative. Then post-radiation therapy or post-radiotherapy, especially for the breast or some other tumor in the chest, you might result in an effusion, generally tends to be an exudate. Asbestos exposure. Remember, asbestos itself can cause effusions, not necessarily a mesothelioma causing effusions. So this asbestos-related effusions generally tends to be benign and tends to have a higher eosinophil content. Clear? And lot of drugs can cause pleural effusion. Very important drug as far as I know is bromocriptine. Then you can get with amiodarone. You can get with nitrofurantoin. You can get with methisergide also. Usually, again, this drug-related pleural effusions tend to have higher eosinophil content with them. Apart from that, many dial-inducing drugs. What is dial? This is drug-induced lupus erythematosus. We have discussed in detail about this dial in the rheumatology chapter. So, dial-induced pleural effusions also tend to have a lot of eosinophils, and they also tend to be one of the important causes of drug-induced pleural effusion. So dial-related drugs, you have a mnemonic for that, which you have discussed in rheumatology. So stay tuned and see the rheumatology videos for better understanding. So in this, the most important and very regular question will be on bromocriptine-induced effusions. It's such a very common entity in people who are taking long-term bromocriptine, especially who are having a prolactinoma. You'll understand once you see those clinical cases. Clear? So these are the basic causes of a transudate versus an exudate. So I have described in detail about all the causes of transudate and exudate so that you need not refer anything else for the pleural effusion. Now let us see some of the important characteristics. The first one, when will you encounter a very low glucose of less than 60 in the pleural fluid? Typically, only one transudate can cause this. That is a urinothorax, which is a very, very rare cause. But it's going to be very common with the exudate. And this is what is important. The first thing in your exam you should answer is rheumatoid arthritis. The lowest amount of glucose you see sometimes 5 to 10 milligrams per deciliter, very low glucose. Such a stereotypical cause for exam. Rheumatoid arthritis, then you can encounter with a malignancy, or you can encounter with a tuberculosis, and you can encounter with a parapneumonic effusion, especially if it's complicated. Parapneumonic effusion, and then an empyema. So these are the conditions which tends to have extremely low glucose of less than 60, but never ever forget rheumatoid arthritis. Even it will have less than 40, less than 20 also. Such a low glucose also has been demonstrated in the pleural fluid. Then you have lymphocytic effusion. Very, very high level of lymphocytes, typically more than 80%. More than 50% itself is fine, but more than 80%, where you're going to see. In India, tuberculosis tends to be the most common, then followed by a lymphoma, rheumatoid arthritis, malignancy, and post-Cabbage effusions, especially in the late period. In the early period, you might have predominance of neutrophils also. In the late period, definitely will have more of lymphocytes only, post-Cabbage. But in India, it's always TB is the first possibility. Third one, high amount of eosinophils in the pleural fluid. Typically, by definition, if it is more than 10%. Whenever there is high amount of eosinophils in the pleural space, it usually indicates presence of air or blood in the pleural space. That's a simple thing. Air or blood in the pleural space, which means you can get with a hemothorax, that is for blood in the pleural space, and air in the pleural space is pneumothorax. You might get with the pneumothorax also. Apart from that, you can see in certain other conditions like Churg-Strauss syndrome, benign asbestos-related effusions. As I told you previously, drug-induced effusions. All these things we have discussed already. Drug-induced effusions, pulmonary infarction, infarcts of the lung, or in certain parasitic diseases related pleural effusions also tend to have a higher eosinophils in the pleural fluid. Clear? So these are some of the examples. Then very importantly, we have to discuss about the left-sided effusions. What are the effusions that will be generally tend to be left-sided classically? Typically the gastrointestinal causes, especially the two important gastrointestinal causes. One is the pancreatitis related pleural effusion. Second one is the esophageal rupture. And the third one, you can think about post-Cabbage related effusions. And fourth one, if they still wanted you to know, Dressler syndrome. All these things tend to be left-sided effusions. Clear? Then, if they ask you some few examples of a right-sided effusion, you can typically answer hepatic hydrothorax and cirrhosis. Hepatic hydrothorax and cirrhosis. Then you can tell PD-related effusions. PD effusions generally tend to be right-sided. And your Meeks syndrome. Meeks syndrome also generally tends to be right-sided. I told you the reason. All this is the ascitic fluid that is going through the diaphragmatic defect, especially on the right side. So that's why they are right-sided typically. You know that. But apart from that, I don't know whether they will ask you that or not, especially, in your entrance examination, but these could be real questions for your practical exams. Then fifth one, how to diagnose a TB effusion. And this is very important, something very important to understand. How will you diagnose a TB-related pleural effusion? TB-related effusion, usual tests, routinely what we do is the protein content, sugar content, and ADA, then AFB staining, cultures, gene expert. All these things are routinely done in India, but what all should be done and what all should not be done and what are indicated, how to diagnose and what are not indicated, that's what we're going to see here. TB. First one, you have to know what is the gold standard for diagnosing for pleural TB diagnosis. What is supposed to be the gold standard? The gold standard for diagnosing pleural TB is pleural biopsy. You have two needles, Abraham's needle and Cope's needle, which we'll see how they look like in some time, but pleural biopsy is supposed to be the most common, most important and the gold standard for diagnosis of this pleural tuberculosis. Gold standard, pleural biopsy. Clear? And typically this pleural biopsy is taken with the help of VATS. So even though you can do a direct needle biopsy, but generally currently what is preferred is by doing a VATS. That's called a video assisted thoracoscopic surgery. Apart from that, one more way where you can diagnose this pleural TB is by testing for ADA. Levels which generally tends to be more than 40, less than 40 rules out, and more than 70 almost confirms it's a pleural tuberculosis and the related pleural effusion. If you diagnose through ADA, this is what we refer to as something called a clinically diagnosed tuberculosis. Very, very important. Especially this 40 threshold is very good in countries like India, where you have a lot of TB cases compared to any other parts of the world. And similarly, in the pleural biopsy, what you're going to look for is the characteristic caseating granulomas or granulomas that show caseous necrosis. And AFB is one test that is routinely performed, but I don't think the yield is good. Yield is very, very poor. I've never seen a single pleural fluid coming AFB positivity till now. I don't know the validity of the test till now, but even though a lot of studies tell yield is approximately around 0 to 10%, but the truth is in a pleural TB, the pleural fluid will not contain bacteria most of the time. It's a reactive effusion, and the bacteria is actually present in the pleural, membrane only. It's not actually leaking into the pleural space. So it's very rare to get an AFB positivity in a pleural fluid. But even though it's a very commonly performed test, it's cheap so that we do it, so not an issue. But one test according to a lot of guidelines which should not be performed very often is your GeneXpert. That is CBNAT, cartridge-based nucleic acid amplification test. Even though it's very, very commonly performed in India by many practitioners, but still this is one test that is not indicated to be done routinely in a pleural fluid. Remember, in any fluid, pericardial fluid it's not indicated, ascitic fluid it's not indicated, pleural fluid also it's not indicated. The only fluid where you can do a GeneXpert and CBNAT is in your CSF as an adjunctive diagnostic strategy. So apart from the pleural fluid, why they don't advocate this in pleural fluid is because of its extremely low sensitivity, less than 20 to 30%, and such a high costly test and with a very poor yield, no need to do. And again, I told you the reason is because the bacteria is generally not seen circulating in the pleural fluid. That is the reason why all these investigations have a low yield. The gold standard is obviously the pleural biopsy. Okay. So now once we have seen all these things, let us move on to the clinical features. Clinical features, on the involved side, you will have reduced chest movements, and the chest movements will be asymmetric. You will not have equal movement of the chest. There will be asymmetric movement of the chest, which means on the involved side there will be less, on the other side it will be normal. So asymmetric chest movements with reduced movements on the involved side. And there will be reduced tactile vocal fremitus and vocal resonance on the involved side. And you will have a stony dull note on percussion. And there will be reduced or absent breath sounds on auscultation. Clear? But apart from that, your percussion wise, like above the level of pleural effusion, you will have a resonant note sometimes. And above the level of pleural effusion, you might even hear a bronchophony, echophony, and all these signs. All these are different. Clear? So that is what we refer to as something called as Kodaic brand of resonance, and that and all you will be asked in your practical examination. But these are the most important clinical features, and not that great and not that important as well, very common and well known by everyone. Diagnosis of pleural effusion. Diagnosis of pleural effusion, I'm going to do something called a thoracocentesis, diagnostic thoracocentesis. You know how to do a thoracocentesis. We have discussed where to put a needle in our basic lung physiology itself. I think in chapter number 3 or 4, where I told you have to commonly insert the needle on the upper end of the rib, upper surface of the rib, where you don't have the neurovascular bundle. So when you do a thoracocentesis, you have to do what is the normal pleural fluid characteristics. So normal pleural fluid should be clear, number 1, with a glucose almost equal to that of the plasma, and the protein in the range of approximately 1 to 2 grams per deciliter, but less than 2 grams per deciliter, and WBC of less than 1000, and LDH should be less than 50% when you compare with the serum LDH. Serum LDH. Then the pH should be 7.6. Remember, the pleural fluid is alkaline. This fact I told you in the Paranpneumonic effusion in the pneumonia chapter itself, where less than 7.2 acidic pleural fluid is an indication for putting a chest drain. Clear? So these are the normal pleural fluid characteristics. So what are the indications for thoracocentesis? So you have to see the pocket size of the pleural fluid. One of the best investigations, we'll see the investigations, sensitivity and all these things, but the best indications to see the pocket size if it's more than 1 centimeter. For example, if the pocket size of the effusion is more than 1 centimeter, typically an ultrasound, or in lateral decubitus X-ray, if the thickness of the pleural fluid sheet is more than 1 centimeter, in lateral decubitus, thickness is more than 1 centimeter. So these are some of the indications. At least you should have a pocket of 1 centimeter, because this is a very important thing. The radiologist will never touch unless and until your pocket size is more than 1 centimeter, because it's very dangerous and risky. You will poke the lung. At least you need a 1 centimeter pocket size to do a reliable aspiration without injuring the structure. At the same time, you get some amount of fluid for examination. Lateral decubitus, nowadays we don't do it, but anyway, fine, you have to know that also. So this should be the case. First indication, this is the number 1 indication, plus you should have any one of the following, plus you should have any one which I am going to tell. Like if you have an asymmetric effusions generally tend to be exudates, that's why. If you have a fever or chest pain, pleuritic type of chest pain, so you can take a diagnostic thoracocentesis. You can tap them, because it could be a paranpneumonic effusion. Because paranpneumonic effusion, if it's complicated, you have to definitely put a chest drain. So it alters the management. That's why it's an indication to do a diagnostic thoracocentesis there. And if it's not resolving, fails to resolve with diuresis or with your conservative strategy. Very often, if the transurate doesn't resolve with diuresis, then you can tap and see what's going on. So these are some of the indications. But remember, radiological wise, at least 1 centimeter pocket is mandated to do a thoracocentesis. Where you don't need a thoracocentesis is typically for transudate. If you're sure it's a transudate, if you're sure, then thoracocentesis is typically not needed. Only thing that is needed is aggressive diuresis most of the time. Suppose if you still do, if the pleural fluid NT-proBNP is more than 1500, it's definitely CHF. Or if the serum NT-proBNP is also elevated and you have a cardiomegaly and a pleural effusion, definitely it's supposed to be a CHF related transudate only, and straight away you can start a diuresis. For CHF related effusions, if you know it's a CHF, cardiomegaly is there, patient is typically having a CHF feature, don't even do a thoracocentesis. It's not at all indicated, and straight away we can start with the aggressive diuresis. Cirrhosis also, we don't do a thoracocentesis. You know the patient is having a cirrhosis, right side effusion, must be a cirrhosis related. And nephrotic syndrome, again patient is having massive proteinuria and there is no need to do thoracocentesis. In general, the transudate doesn't need thoracocentesis overall. Only exudates do need it. That's why I told you all these facts. So the next question is how to differentiate between a exudate versus a transudate. Exudate versus a transudate. You know, every single medical student who have completed the final year of MBBS must know there is one criteria that is existing called Light's criteria, postulated by Richard W. Light, who has a own book on his name on pleural disorders exclusively, which is an excellent book. And majority of things I have actually, my reference is from his book, Light's pleural disorders, and you have Fishman's pulmonary. These are 2 books I generally use for reference for entire pulmonary medicine. Anyways, what do you mean by Light's criteria? Light's criteria tells you, Light's criteria is to diagnose an exudate. It's not differentiating a transudate or an exudate. It actually tells you if you have these characteristic features in the pleural fluid, it's likely to be an exudate. That's what it's trying to tell. So it's telling you when you take a pleural fluid protein and you compare with the serum protein, if the ratio is more than 0.5, that is, if the pleural fluid protein is more than 50% of what your serum protein is, then it's supposed to be a exudate. Then you are taking LDH in the pleural fluid and you are comparing with the serum LDH, and if it's more than 60% or 0.6, definitely it is an exudate. Number 3, if the LDH in the pleural fluid, I can write a pleural fluid LDH, is more than 2/3 of the upper limit of normal of serum LDH. In this case, you need not do a serum LDH separately. Thus, just ask your laboratory what is the upper limit of normal for serum LDH. They will have a reference range and they'll give you that, and compare the pleural fluid LDH. If it's more than that reference range, then definitely you can call it as a exudate. Remember, if any one is there, itself you can call it as an exudate. You do not have all the 3. Any one is there, you can call it as an exudate. The good thing about the Leitz criteria is the fact that it's not going to miss any effusion at all. It's not at all going to miss any exudative effusion. Clear? Which means the sensitivity is very, very, very high, more than or equal to 99%, which means it's never going to miss even a single exudate. But the problem is it suffers from low specificity of only 83%, which means there is a 17% possibility that the transudates may be considered as exudates according to the Leitz criteria. So that's why we have some criteria, the newer ones, that is going to have higher specificity compared to that of the Leitz criteria, even though they have a lower sensitivity, but compared to Leitz criteria, they have a high specificity. For example, we have something called a gradient rule. The first one is the gradient rule. Specificity is almost 91 to 92% specificity. And this gradient rule is very, very useful, especially in patients who are having a post-diuresis CHF fluid looking like an exudate. I told you after diuresis, the congestive cardiac failure pleural fluid may look like an exudate because of concentrating effect of diuretics. But in those patients, this might be very, very useful. This gradient rule, where we see the serum minus pleural fluid albumin gradient. Albumin gradient, if it's less than or equal to 1.2, it's supposed to be an exudate. Point number 1. Second, you can see serum minus pleural fluid total protein gradient. Total protein gradient, if it's less than or equal to 3.1, again, it's supposed to be an exudate. Clear? So these are the things that will be important in differentiating especially the pseudo exudates from a true exudate. So this is a very important as a high specificity. This is what we refer to as a gradient rule for exudate. Number 2. And remember, pseudo exudates will not satisfy this rule, which means after diuresis, if the fluids look like an exudate, but actually it's not an exudate, it's a transudative fluid that is converted to exudate-like thing because of the diuretic effect, where the Leitz criteria fails, but this criteria won't fail. Clear? Number 2, you have Hefner's 2-test rule. This is called Hefner's rule, otherwise called as Hefner's 2-test rule, where the specificity is almost 98%, which is very good. And all 2 should be satisfied. It's not like any one. To increase the specificity, they have told the 2 rules are given and both should be satisfied. Number 1 is the pleural fluid cholesterol, which should be more than 45 milligrams per deciliter. And this is called rule of 45s also. You will see now why. Pleural fluid LDH is more than 0.45 times the upper limit of normal of your serum LDH. So this is why it's called the rule of 45s also. Clear? So this is called Hefner's 2-test rule, and if both are present, the specificity for an exudate is 98%. You can add another rule, third one, where you can tell pleural fluid protein, if it's more than 2.9 grams per deciliter, if you add all these 3 things, along with that one more thing also if you add, and if all 3 are present, now the specificity becomes 99%, almost 100% nearly, and this is what we refer to as a 3-test rule. Along with the Hefner's rule, if you add one more entity, that is pleural fluid protein more than 2.9 grams per deciliter, that becomes a 3-test rule, and that 3-test rule has almost a specificity of 99 to 100%. So now this thoracosynthesis itself has some complications. So what are the complications? Complications number 1 is pneumothorax because of injury to the pleura and the lung. Second one is hemothorax. Again, is due to iatrogenic trauma. Third, you have another one called re-expansion pulmonary edema. And they will definitely ask about this multitude of times in your exam. Re-expansion pulmonary edema. The risk of re-expansion pulmonary edema is very high when you are trying to tap more than 1.5 liters of pleural fluid. So try to be less aggressive in tapping. So do not tap more than 1.5 liters. Try to tap less than 1.5 liters. Like re-expansion pulmonary edema in the sense because dramatic sudden expansion of the lung because of sudden removal of a lot of pleural fluid will result in capillary leak and you might result in pulmonary edema in the alveoli. So that is the reason of the pulmonary edema here. So avoid tapping more than 1.5 liters as much as possible. Then visceral injury. Visceral injury, typically liver or spleen related injury, and this injury can be seriously minimized by using ultrasound guided tapping. But I generally use only ultrasound as a diagnostic modality for effusion as well as for tapping purpose. All we use either bedside ultrasound or we send to the radiologist who does this job very perfectly. But anyway, visceral injury is a real-time risk, but especially this will be dramatically decreased if you are using ultrasound guided tapping. Okay. Then we are entering the whole new field of imaging the pleural fluid, pleural effusion. Imaging the pleural effusion is a big topic and you have to know the sensitivity of various imaging modalities in imaging the pleural effusion. So what are the various modalities that can image the pleural effusion? Point number 1, you have sensitivity for CT which can detect up to 10 ml, followed by ultrasound which can detect up to 20 to 30 ml, followed by chest X-ray, and chest X-ray will depend on view, what view you are taking. Clear? But on paper, CT is supposed to be the most sensitive modality, 10 ml. But who is going to do a CT for detecting a pleural effusion? That looks very rubbish. So in general, ultrasound is the most commonly performed technique for quantifying the amount of pleural effusion. At the same time, for tapping also, at the same time, it can localize the pockets of effusion also, or it can check for the loculations also. So many things are there. But as far as I know, this is not something comes from the textbooks. As far as I know, this is the best thing to evaluate a pleural effusion. Among the imaging techniques, I feel the ultrasound is going to be the best modality for looking out for the characteristics, nature and size of the effusion. Because the CT, again, to characterize and localize an effusion alone, your CT is not going to play a big role at all. Clear? Anyway, for effusion facts, your ultrasound is going to be the best because it's very, very sensitive. At the same time, you can delineate the characteristics also, and it's non-radiation. You don't have a radiation with ultrasound. So it can be done in bedside. So many advantages are there easily. So chest X-ray wise, I told you it depends on the view of the chest X-ray. So what are the views we have? If they ask you the most sensitive chest X-ray view, it's supposed to be the lateral decubitus. Lateral decubitus view, where you have a sensitivity of approximately 50 to 75 ml can be detected. So in the lateral decubitus, what we tend to do, it's like a PA view. Don't think it's a lateral chest X-ray. Lateral chest X-ray is different from a lateral decubitus view. Lateral decubitus view, you can imagine like it's a modified PA view, where in a PA view, what you will do, the patient will be standing with their backs facing the X-ray machine, and you have the plates in the front, right? So the X-ray will come from the back. This is what we call the posterior view. Lateral decubitus view is also like a modified PA view only, where the patient will be lying on one of the lateral decubitus, either left lateral side or right lateral side, whichever side the pleural effusion is suspected, that side the patient will be lying. It's a dependent position, and you will be taking the same PA direction. X-rays will be coming from the back, and the plate will be, put in the front, and that's all. It's a modified PA view, but the patient will be in lateral decubitus posture. That's all. So here what will happen is if there is a pleural effusion on the left side or the right side, you're going to have layering effect. The pleural fluid will come and layer on the sides. So that layering thickness you have to see. If it's less than 1.5 centimeter, it tends to be small. And if it's 1.5 to 4.5 centimeter, it's supposed to be moderate effusion. And anything more than 4.5 centimeter of thickness of the fluid is supposed to be a massive effusion or a very large effusion. Clear? So in the lateral decubitus, so this is what you're going to see. And apart from that, in the lateral decubitus itself, you have one more sign called blunting of posterior costophrenic angles. Blunting of posterior CP angles. That will typically happen at approximately 75 ml. But this layering effect will happen at 50 ml itself. And that's why I told you the sensitivity is approximately 50 to 75 ml for a lateral decubitus. Remember, posterior CP angles are different, lateral CP angles are different. In a PA view, you see the CP angles, blunting CP angles, blunting, that term will be used very commonly, but what CP angles are blunted in a PA view is the lateral CP angles. But in a lateral decubitus, you are looking at the posterior costophrenic angles. Clear? That's what will be blunted. So the next one, apart from the lateral decubitus, the first one we saw in the chest X is lateral decubitus. Second is the standard PA view. Standard post-anterior view, PA view, where the sensitivity is approximately 200 ml. So it means it's less sensitive compared to that of the other investigations. But still, it's worthwhile. It's very useful. So first sign in a standard PA view is going to be blunting of the lateral CP angles. Blunting of the lateral costophrenic angles, which I'll show in the X-ray in some time. At the same time, you also have to understand that it's one of the very commonly seen signs in the chest X-ray. And when will you need, how much pleural fluid you need to produce diaphragmatic contour obliteration. So if you want to produce a diaphragmatic contour obliteration, which means the entire diaphragmatic contour itself is not visible, that happens at approximately 500 ml. Clear? And most often you will see one important sign called meniscus sign. Meniscus sign in the PA view. So this meniscus sign is an X-ray artifact. Even though, like many times, for a lot of times in the history, it has been thought as a real sign, and a lot of explanations have been given for that. But typically, it has been proven by multiple experiments from the 1930s and 40s itself, clearly proving it's just an X-ray artifact. Like for example, in PA view, if you see, it tends to form a meniscus. For example, in the medial side, it tends to be at a little bit lower, the effusion level, and as you move up in the lateral, the effusion tends to be going a little bit higher like this. So this, like the medial side a little bit lower level of the effusion and the lateral side having a little bit higher level of the effusion is typically an X-ray artifact, and it's not a true thing that you see. Even when you take a CT and all and see, it's not going to be the case. And even if you tap and see, it's not going to be the case. And this is just an X-ray artifact, and this is what we refer to as meniscus sign. So which means, what is meniscus sign? Sloping of the pleural effusion. Medial lower level and laterally little bit higher level in a standard PA view is what we refer to as meniscus sign. Suppose if the opacity reaches 4th rib, if the fluid level appears to reach the 4th rib, you are supposed to have at least 1000 ml of pleural fluid in the pleural space. So initially I started with 200, then I told with 500, then I went with your 1000. Remember, blunting of CP angles means it happens at 200 ml. So 200, 500, 1000. Clear? So just blunting of the CP angles, lateral CP angles 200 ml, diaphragmatic contour obliteration 500 ml, reaching the 4th rib, anteriorly it is 1000 ml. Then third one, you have subpulmonic effusions. Subpulmonic effusions. Generally, they can look like a new beginner who's looking at a subpulmonic effusion may think like it's an elevated diaphragm. But typically, they form a sign called Rock of Gibraltar appearance or Rock of Gibraltar sign, which I'll again show you. And many times, this subpulmonic effusions may be mistaken for your elevated hemidiaphragm. The diaphragm itself is elevated, that's what you will think, but it's not the case. And next is the ultrasound. As I told you, ultrasound is one of the very, very important investigations for evaluating, and according to me, it's the best investigation for assessing a pleural fluid. So, what are the signs that you will see in ultrasound? One is thoracic spine sign. It's a very easy thing to understand. The fluid itself is very easy to pick up in the ultrasound, but apart from that, some named signs, if you want to tell, first is the thoracic spine sign. What do you mean by thoracic spine sign? Suppose if you have, this is the lung, and the pleural space in the chest wall. Let us assume, and this is the vertebra. And you have the spinous process here. Clear? Let us put one more time. Suppose if you put a transducer here and you put the ultrasound waves, and you're not going to see the spinous process above the diaphragm, because above the diaphragm you will have this lung. Since the lung material will not conduct the airway sound at all, because air and sound waves, especially the ultrasound waves, doesn't go well with each other, especially with regards to ultrasound. But water and ultrasound waves love a lot. They transmit very nicely, but air is not going to transmit, and it's going to scatter the waves very badly. So since the lung is fully made up of air, if there is lung in between, I will not be able to see the spinous process. Above the diaphragm, it's not possible to see the thoracic spinous process. Suppose if you have an effusion means this area of the lung will be collapsed. So this area of the lung will look something like this, and now this area will be filled with pleural fluid, right? So this is an effusion. So when you do an ultrasound above the level of the diaphragm, and now this pleural fluid will transmit the ultrasound waves, and now you can clearly see the thoracic spinous process. And this is the reason of this thoracic spine sign. This is what we called as a thoracic spine sign, because fluid is an excellent acoustic medium, we all know that. And number 2, we have a sign called a quad sign, then something called a sinusoid sign, otherwise referred to as jellyfish sign. During inspiration, obviously this is what we called as like a jellyfish, it will go like this, isn't it? Jellyfish movement will be like this only, like this. So like that, during inspiration, the size of the effusion will decrease. Depth of the effusion size will decrease during inspiration because of probable little bit expansion of the lung. The fluid might be little bit going to the sides, and the depth of the effusion actually decreases like a jellyfish. So this is what we refer to as a jellyfish sign or a sinusoid sign. Number 4, we also have something called a plankton sign. Plankton sign is generally seen in a exudative effusion where a lot of proteinaceous particles will be there that looks like a like hyperechoic substances in a hypoechoic fluid. So this kind of small dot like appearance in a pleural fluid is what we refer to as plankton sign, and that is a sign of an exudate. So these are things you are going to look out for the signs. Now let us see some of the images. You can see this is a lateral decubitus view where you can see this layering of the pleural fluid here, and this is the layered pleural fluid on the right side in this case, and you can see the thickness and you can estimate the severity of the pleural fluid. And you can see it's a very large pleural effusion. Definitely it will be more than 1000 ml because it's reaching the 4th anterior rib. And you can also see it is showing the characteristic meniscus sign, sloping of the level of the pleural fluid from medial to lateral side, medial being at the lower level and lateral being at a higher level. And this is a typical example of a subpulmonic effusion. Subpulmonic effusion. Clear? So where you can see very clearly that this patient is having, it's looking like actually a elevated hemidiaphragm, but it's not. This is actually the pleural fluid here. Clear? That is producing elevated hemidiaphragm like appearance, and this is what we refer to this talk of Gibraltar appearance. We know this already. We have learnt it. And if you see a straight line like this with an effusion, this is suggestive of a hydropneumothorax, where there is a pneumothorax as well as effusion coming to that. It could be hemopneumothorax also. In case of a trauma, you can diagnose a hemopneumothorax. Okay, all right. Then actually this patient is having a TB. You can see that. You can see some infiltrates in this area. On the background, you can see a lot of infiltrates that is passing here. So this is supposed to be a right-sided TB actually. So that's what my diagnosis will be. Anyways, you can see this is another example of a very loculated effusion. You can see this is another example of a loculated effusion. And this is how in ultrasound you pick up. In ultrasound you can see this is the diaphragm and this is the liver, and you can see the pleural effusion in this area. Clear? And this is the lung on the top. So this is how you diagnose pleural effusions typically. Now, when we do a pleural biopsy, what are the indications of doing a pleural biopsy? We typically do only for indeterminate cases. Indeterminate cases where effusion is not diagnostic at all, but very commonly in India, what we do is for diagnosing pleural tuberculosis. Clear? So that is where you diagnose. Suppose if you have not a very high ADA level, but still it's strongly suspective of like pleural tuberculosis, then you can do a pleural biopsy. Typical way where we do a pleural biopsy is VATS, but alternatively in old age era they used to do with some biopsy needles also straight away. But without VATS, using straight away these biopsy needles is currently not a choice, not an option. So send to VATS as much as possible. So what are the biopsy needles? So these are the two biopsy needles that are available for the pleural biopsy. The one is what we refer to as the Cobb's needle, and second one we call it as the Abrams needle, this one. So this is the Cobb's. Cobb's has a gauge also along with it. This is a safety gauge, so that is what you're going to see. But Abrams will not have any safety gauge like this. So that's the difference. So Cobb's versus Abrams needle. Let us see an overall understanding of how to analyze a pleural effusion. So evaluation of a pleural effusion. We have seen a lot of things, but we have not integrated everything into a single chart. Let us try to do that. First, whenever a patient is having a pleural effusion, confirm, see whether it is really significant or not. So how will you see whether it is significant or not? If it is at least having more than 1 centimeter pocket in the ultrasound, which I have told you already, or if it is having at least more than 1 centimeter thickness of the effusion fluid in the lateral decubitus posture. So if it is not significant, just observe this patient, no need to do anything. If it is significant, then look for clinical features of a transudate. If the clinical features are suggestive of a transudate or not. Like heart failure. Very commonly what you're going to look for is a heart failure. For example, these patients may have pedal edema, then elevated NT-proBNP in the serum, and bilateral basal crepitations. All these things will tell you the patient is probably having a transudate to an extent. So if yes, clinical features suggestive of transudate is there, just you are going to treat conservatively. It's a conservative treatment. Very commonly what we are going to use is diuresis. So but still here there are some indications of thoracocentesis. Indications for needle thoracocentesis or diagnostic thoracocentesis. What are going to be the indications for a diagnostic thoracocentesis in this particular patient? Point number 1. Suppose if the patient is having an asymmetric effusion, especially if it is associated with a chest pain or a fever. Very, very important. So it could be a cardiac failure patient with a pneumonia causing parapneumonic effusion. So you have to be very careful. Asymmetric effusions with maybe plus or minus a chest pain and a fever will have more relevance in fact. So these patients definitely should be taken for thoracocentesis. And number 2, if the effusion is persisting after 3 days of aggressive treatment of diuresis. So definitely these patients also has to be taken for thoracocentesis. Apart from that, generally don't need, just you can treat with diuretics and you can just observe and no further testing is needed. So if there are no features suggestive of a transudate and you already know it is a significant one having more than 1 centimeter pocket, so do a diagnostic thoracocentesis. Diagnostic thoracocentesis. So what you're going to see in the diagnostic thoracocentesis is the typical Leitz criteria. Leitz criteria. So Leitz criteria may be positive or Leitz criteria may be negative. Suppose if Leitz criteria is negative, it's very likely to be a transudate. likely a transudate. Clear? Because Light's criteria have very high sensitivity. We have seen already it's not going to miss out any exudate. So if it's negative means it's very likely a transudate. Look out for cause of transudate like cirrhosis, nephrotic syndrome and heart failure. Very common it will be the heart failure. So now if the Light's criteria is positive, it's likely an exudate but not all the time. It could be a pseudo exudate also, but anyways, likely an exudate. Clear? Now, if you have a suspicion of this being a pseudo exudate, which means heart failure already treated with diuretics, if you have that kind of suspicion, you can see other criteria, apply other criteria. Typically, what we use is the gradient rule. Clear? Or we can use the Hefner's 2-test rule or 3-test rule. Apply other criteria. If the other criteria are negative, likely it's a transudate that is showing exudative features in Light's criteria. Or if the other criteria becomes positive, then you can confirm it's an exudate. Exudate is almost confirmed. It's an exudate. Remember, here itself you can confirm an exudate if you don't have any suspicion for pseudo exudates. But if you have a suspicion for pseudo exudate, then only you have to apply other criteria. Otherwise, it's really not needed in the first place. You have to be very careful. So let us now know it's an exudate. So now after confirming this in exudate, either by Light's criteria or by other criteria, now you have to do a full pleural fluid analysis. You have to do a full pleural fluid analysis. Typically, this will include doing protein, glucose, plus or minus albumin, then your gram stain, cytology, cell count, adenosine, deaminase, culture sensitivity, plus or minus AFP. So these are the standard panel that we are going to do. You have a lot of additional panel also. For example, in special cases, you can do amylase. If you're thinking about a GI causes, you can do a hematocrit if you want. You can do a pH. You can do LDH. Clear? A lot of things. You can do even a creatinine. So a lot of other additional things. These are optional things, but this should be the standard one. Clear? So the entire thing will come under the full PFT. So ideally it is to do a full pleural fluid analysis, completely do a pleural fluid analysis and check what is the possibility. Clear? So with this you are able to make a diagnosis or not. So whether you are able to achieve a diagnosis or not. If you are able to achieve a diagnosis, then treat that particular cause. That's it. If you are not able to make a diagnosis, even with a full, complete pleural fluid analysis, then you can go for CT angiography. Because sometimes, very notoriously, it could be a pulmonary embolism. That's why. Do a CT angiography. So, in CT angiography, if you are seeing an infiltrate, then next step is to go for a bronchoscopy and do a washing. It could still be a TB. And if it's a pulmonary embolism, you're going to give anticoagulation as the next step. That's the treatment, right? If it's a mediastinal lesion, which means it is likely to be a tumor, then do a mediastinoscopy and needle aspiration. Or a FNA, needle aspiration. Again, if it's non-diagnostic, so now you have two options. Either you can observe the patient or you can do a VATS. Any one, VATS or a thoracoscopy, open thoracoscopy or a VATS. Any one option is there. Commonly what we perform is the VATS in this kind of cases. If you still don't have a clue, do a VATS. Suppose VATS, when it is done, if you have a very high degree of suspicion, still for a tuberculosis or a malignancy, in this condition, better to do a VATS. So these are some of the important algorithmic approach of how to manage a pleural effusion in an algorithmic way. Fine, clear? So whenever I told you, if the diagnosis is made, how you are going to make a diagnosis? For example, a lot of ways you can make a diagnosis. Like for example, if ADA is more than 40 in India, it is supposed to be tuberculosis. If you see malignant cells in cytology, it is supposed to be a malignancy. So, or if the hematocrit is more than 50% of the blood hematocrit, then you can consider a hemothorax. If your amylase levels are raised very high, then you can think about gastrointestinal causes like pancreatitis or esophageal rupture. Depending on other CT abdomen images, you can find out what is the cause and you can do a serum amylase and all the other investigations. Similarly, if the pleural fluid creatinine is very high, it is supposed to be a urinothorax. These are very rare causes. If the pleural fluid glucose is extremely high, then you can think about a PD pleural effusion. PD pleural effusion. So these are some of the elements that you have to look out for. But anyway, so I told you some examples of how to go about a diagnosis of different types of pleural effusion. In that, you also have to know how to manage a parapneumonic effusion in a suspected parapneumonic effusion. Suppose let us assume a patient who is having a suspected parapneumonic effusion. So how to manage this? So do a chest ultrasound. Typically we do a chest ultrasound. I told you one of the best investigations to see the nature of the effusion. So you have to see whether it's loculated or non-loculated. Remember, whenever it is loculated, parapneumonic effusion has a high chance of getting loculations because its fibrinous stance itself will form loculations and it's really difficult to remove this fluid in the first place. So there are no loculations, which means it is non-loculated. Loculated patients, there is no doubt, you have to straight away go for chest drain, plus or minus thoracoscopy. Straight away, you have to break the loculations. At the same time, to break the loculations, you also need a fibrinolytic agent, plus or minus decortication. If still not responding, you will go for decortication. But remember, loculated effusions need a chest drain. We have discussed this point already. Clear? Then, you also need a thoracocentesis. Why you need a thoracocentesis for loculated effusions? To see the nature of the fluid, for that you need. But anyway, straight away loculated effusions means you need a chest drain. That's a very, very important point to know. If it's non-loculated, typically the next step will be doing a thoracocentesis. In the thoracocentesis, see whether it is frank pus or if it's serous fluid. So if it's frank pus means you're dealing with a empyema. Straight away, you have to go for chest drain in these cases. Chest drain, and obviously this pus, you also have to send for culture sensitivity and gram stain because you have to identify what organism that you are dealing with. So depending on that, you can give antibiotics. So this is how you deal with the empyema. Plus or minus, they themselves may need a fibrinolytic agent infusing into the pleural space to break the loculations and make it very clear, and so that the fluid flows much better. Plus or minus, they also may be needing a decortication. Clear? Yeah. So if it's a serous fluid, then very importantly, you have to see the pH. If the pH is more than 7.2 or the pH is less than 7.2. The pH is more than 7.2, you have to just observe the patient. There is no need to do anything, or you might be needing a just therapeutic thoracocentesis. Therapeutic thoracocentesis. If the pH is less than 7.2, we have discussed this fact many times, it indicates a complicated parapneumonic effusion. Complicated parapneumonic effusion. So in this condition, you have to definitely insert a chest drain. If they are developing loculations, you might be needing a fibrinolytic therapy. That's all. But apart from that, chest drain is needed if the pH is less than 7.2 in a serous fluid with, which means it's a complicated parapneumonic effusion. So this is how you're going to evaluate a suspected parapneumonic effusion. And again, a very easy thing to understand. So here the take-home point is very simple. In any suspected parapneumonic effusion, which means patient is having a pneumonia and a effusion together. So indications of chest drain will be three things. One is lock-rate effusion. Second is your empyema. And third one is complicated parapneumonic effusion where the pH is less than 7.2. Other indications are LDH more than 1000. And if the culture sensitivity is positive or if the cramp stain is showing some organism in the serous fluid itself. So these are some of the indications. Three indications: complicated parapneumonic, empyema, lock-rate effusion. That's it. So these are the three important indications for a chest drain in a parapneumonic effusion. That's all. Suppose if you are having a suspected tuberculosis, so what you're going to do? Suspected tuberculosis, suspected TB, how will you approach? We are talking about a pleural TB, not a pulmonary TB. Pulmonary TB, we have a separate guideline. If it's having a pleural TB suspicion, the next step is to look for the ADA, adenosine deaminase levels. If ADA levels are more than 40 or less than 40. Less than 40 is highly unlikely to be tuberculosis. More than 40 is likely to be tuberculosis. Clear? So even though if it's unlikely to be tuberculosis, if you have a high suspicion for tuberculosis, in this condition you can take the patient for a pleural biopsy, typically by VATS, video assisted thoracoscopic surgery. If it's more than 40, definitely it's likely to be a TB, but still you have some other suspicion also, you can do a VATS. But anyway, typically in India, more than 40, we generally take it as a TB, and you can start ADT therapy. This is what we refer to as something called a clinically diagnosed tuberculosis. This is how you approach to a suspected tuberculosis. Similarly, you have suspected malignant effusions also, how to treat them. Suppose if you have a suspected malignant pleural effusion, we call them as MPE. Suspected malignant effusion or malignant pleural effusion, do cytology. The first thing you have to look out for is the cytology. If the cytology is showing malignant cells, if the cytology is negative, the cytology is going to show malignant cell straight away, you can diagnose it's definitely a malignancy. There's no doubt about that. There's no need of any further investigations. If the cytology is negative, which is the case in most of the scenarios, you can do an ultrasound plus or minus a CT contrast of the chest. We call it a CECT chest. Here you can look for three things. Either it's a lock-related effusion, or if it's a patient who is not having a pleural thickening or loculations, or if a patient who is having a pleural thickening. Pleural thickening usually goes towards mesothelioma in this case. That's why when you are suspecting malignancy, means when you have pleural thickening, you have to suspect a mesothelioma. If you are having a pleural thickening, next step will be a pleural biopsy. Clear? So if you have a lock-related effusion, the next step will be to do the thoracocentesis. Thoracocentesis. If thoracocentesis once again showing malignant cells, straight away, there's no doubt about that, it's a malignancy. Suppose if thoracocentesis is not showing any malignant cells, I'll be again doing a pleural biopsy if I have a high suspicion for malignancy. If there's no pleural thickening, then I have to look for loculations. If there are no loculations, then again I can do a thoracocentesis in this scenario also. Again, the same algorithm will be applicable. Same algorithm will be applicable. Clear? So this is how you can classify a patient who's having a suspected malignant pleural effusion. Clear? So we have almost seen every single approach for how to diagnose a pleural effusion, but the most important of all is the first one which we have discussed, how to evaluate a pleural effusion. So this is going to be the most important one. So this is the ultimate flowchart that you need to know. Apart from that, in a suspected parapneumonic effusion, how to do. And again, they won't ask you all the algorithms, but most important 3 indications of your chest drain. One is the lock-related effusion, second is the complicated parapneumonic effusion where the pH will be less than 7.2, and third one is the empyema. So these are the 3 standard indications. Apart from that, TB, you will do pleural biopsy only if the AD is inconclusive or if you are having suspicion of TB, but you don't have proper evidence for diagnosing TB. So in those cases, you can diagnose a TB through a pleural biopsy. So this is how you approach a TB, and finally, how you approach a malignant pleural effusion. So look for the cytology, that's the most important. We had to look for the malignant cells. If nothing is conclusive, then you will be going for a pleural biopsy to rule out a mesothelioma. That's all. So then, what are the treatment options for pleural effusions? Typically, you don't treat transient. We have discussed all the treatment options already, but there are certain areas where you need. For example, in acute symptomatic cases, where the patient is having breathlessness plus relatively large effusions, in these patients, again, it has to be managed by case-to-case basis. Treatment depends on case-to-case basis, but in general, you can do a needle thoracocentesis in urgency. If urgent, you can do a needle thoracocentesis. Clear? You can do a needle thoracocentesis. But if you get a frank pus, you can put a chest drain directly. If you get a blood is coming out, especially if you are having a traumatic pneumothorax, then you can put a chest drain directly. So again, it depends on case-to-case basis for having acutely symptomatic effusions. But in general, even if it's a transudate, if the patient is symptomatic, you can go for needle thoracocentesis, not a problem. Then obviously, if it's going to be tuberculosis, you're going to give ATT. Or if it's a malignancy, how you're going to manage? If it's a malignancy, you're going to manage by different way because malignant effusions are generally inoperable. So there is no point in operating. And at the same time, even if you remove by thoracocentesis, it's going to come again and again. So what are you going to do? There are options for malignancy. Again, it's a palliative care only. So you can do something called a serial thoracocentesis. So where you prick the patient again and again, or if you don't want that, if it's very annoying for the patient or for the doctor, then you can try a pigtail catheter. Pigtail catheter is an indwelling catheter. We know that. Which will live in situ and it's going to drain slowly over a long period of time. Number 3, you can do a pleurodesis, which is one of the best options for malignant patients for palliative care. Pleurodesis is typically done with the help of chemical pleurodesis, or you can do a surgical decortication also. That is something which we don't advocate in malignant patients, and we avoid surgery as much as possible because it's a palliative care. So pleurodesis-wise, 3 things can be tried. One is talc, second one is tetracycline. Typically, we use doxycycline for that purpose, and the third one is bleomycin. Let me write again, tetracycline and bleomycin. In this, among the 3, your talc has the highest success rate among the 3, and it is also the most commonly used pleurodesis agent. Clear? And decortication is also an option, but in malignancy patients, we don't generally try this decortication. And one more important thing is, do not try to attempt a chest drain in a patient with a hepatic hydrothorax at no cost. You will not be able to remove the drain because the criteria for removal of the drain will never be achieved. Correct or not? So you will never be able to remove, so never insert a chest drain in a patient who is having a hepatic hydrothorax. So finally, what are the indications for chest drain? One more time. What are the indications for chest drain? Classical indications only 3. Any lock-related effusions. Number 1. Number 2, complicated parapneumonic effusions. Number 2. And number 3, empyema. Classic indications in medicine. Apart from that, surgery has a lot of indications for putting a chest drain, but medically these are the indications. Hemothorax is an indication. Pneumothorax is also an indication. Hemopneumothorax is an indication, especially if the patient is having your acute decomposition. The patient is having shortness of breath and all these things. So a lot of other indications of chest drain are there, but classically in medicine, these are the 3 characteristic indications for a chest drain in case of a pleural effusion. And you also have something called a criteria for removal. So what are the criteria for removal? The first criteria for removal is output you are going to see. So output of the drain, is it less than 100 ml to 300 ml per day? That's what you're going to see. If it's less than 100 ml to 300 ml per day, definitely it's one of the criteria for removal. At the same time, lungs should be adequately expanded. So the lungs are adequately expanded. Again, it's one of the very important criteria for removal of the drain. So these are the very, very important criteria for removal of the chest drain. Apart from that, I think we have covered in and out about the pleural effusion as much as possible. This much, if you know, is going to be more than enough. It's a very common topic and very important topic also, especially for undergrads, even for postgrads. So be very thorough. And even if you have some extra points, please make a note of it in your notebooks. And all the best for this topic.